Morning, everyone. It's my privilege this morning to introduce our speaker, who I think most of you know anyway, but I will introduce Dr. Alsidawi. Saeed joined us in August. He did his medical school and started out in Damascus and finished up at Georgetown and Baylor. Sometime you'll have to tell me how that worked between the two. And then he was a fellow at the University of Cincinnati, and he won the Outstanding Cardiology Fellow Award at that institution. Following that, he spent a year level 3 structural heart training at the Mayo Clinic, and he continues to have a relationship with Mayo Clinic in that respect. I can tell you that I've worked with Saeed when he first joined the practice in Waukoni. He's a great cardiologist. He's very well liked by his patients and everyone out there, and he's very skilled in echocardiography. He's published about 21 manuscripts and continues his interest in research, and this morning he's going to speak to us about assessing low-flow aortic valve stenosis, one of a common problem for us right now. So welcome, Saeed.
Good morning, everyone. Thanks for being here this morning. Dr. Sharkey has invited me to talk about some of the work that I've done and continue to do actually with Mayo over the last year or so. So I use this as my objective slide because my goal today, I'm not going to show you anything that you've never seen before. It's just we're going to rethink some of the concepts we use on a daily basis in the echo lab. So let's see if I'm successful with that. So we all know the current guidelines for severe aortic valve stenosis. This is the 2014 guidelines. Nothing really changed. But how often do we see this? Actually, I feel that we're more often faced with discrepant hemodynamics, where the valve area is in the severe range, but the mean gradient and the peak velocity are in the moderate, sometimes in the mild range. This is actually one of the biggest challenging for an echocardiographer even, trying to interpret these findings. So I'm not going to go over measurement errors today or anything. I'm going to assume that these hemodynamics are truly related to low flow conditions, and I'm going to discuss a couple of conditions that cause this. So when we have these discrepant hemodynamics and we have a low flow condition, so as you know now, we have two conditions that cause it. One, the classical low flow, low gradient aortic stenosis, where the ejection fraction is less than 50%. And then the paradoxical, or the low flow, low gradient aortic stenosis with preserved ejection fraction. Now that has been a topic of a recent grand round, so I'm not going to discuss it in a lot of details. I'm going to focus more on the classic low flow, low gradient AS today. But from all the causes of paradoxical low flow, low gradient AS, I'm just going to talk quickly about how atrial fibrillation plays a role in that and what we've done to improve our assessment of aortic stenosis in this condition. So we get started with the low flow, low gradient aortic stenosis with reduced ejection fraction. So that's how it's defined in the guidelines. So it's when the ejection fraction less than 50%, you have a mean gradient less than 40, and a valve area less or equal to 1 centimeter squared. So as you see in this definition, and we'll come back to that later on, flow is defined by low ejection fraction. And that's actually still being how the guideline defines it. Now, as you know, this represents one of two conditions, and that's why we use the dobutamine echo in these conditions. Either a true severe aortic stenosis condition, where if you give dobutamine, the valve area would remain less than 1, but the mean gradient will go above 40. Or the non-severe AS or pseudo-severe AS, where the valve area would go above 1 when you give dobutamine, while the mean gradient remains less than 40. So I apologize, some of these videos I brought with me from Mayo, so they're type B format, so you're going to see the left ventricle on the left. So that's the case in this one here. So this is just an example here of a patient who's 62-year-old with ischemic cardiomyopathy, EF maybe 35–40%. And he has the set of hemodynamics you have here, aortic valve area of 0.8. The mean gradient of 24. So if you ask, majority of people, I'm assuming in this room would say, like, to further investigate this, whether it's severe AS or not, people would give the dobutamine echo for this patient. So I'll come back and talk about this in more details here. So this is the protocol we use currently, and this is probably for our sonographer who are here today. So as you see, what's different about this protocol is you stop at 20 micrograms of dobutamine. You don't go to 40. The reason is most data show that your cardiac output peak at 20 micrograms of dobutamine. So there's no point of going further. I think the important point is that you have to check your stroke volume and all your hemodynamic data with every stage of dobutamine use. The reason is a lot of these patients also have coronary artery disease. So it happens that their stroke volume improves at low doses of dobutamine and then starts dropping. So it's important to assess at every stage, and you use the highest stroke volume and the hemodynamics that you achieved with the highest stroke volume. It doesn't have to be the peak. I think this is an important point here. So let's see examples here of how people respond to dobutamine. So this is a patient with low ejection fraction, stroke volume 42 ml or cc, mean gradient 22, and aortic valve area 0.8. So he gets dobutamine, stroke volume improves, mean gradient goes to 41, and valve area remains less than 1. So this is an example of true severe aortic stenosis. On the other hand, you have this patient with a stroke volume of 55 ml to start with, again, low ejection fraction. His mean gradient is 20 and aortic valve area is 0.9. You give them dobutamine, stroke volume improves, mean gradient remains low in the mild to moderate range. Valve area goes up to 1.25. So this is an example of somebody who has aortic stenosis and happened to have a low ejection fraction from a different reason. And when we improve their flow condition, their valve areas improved. They were just not able to open their valve because of their low flow condition. You have patients who do this, and actually we're seeing these more commonly now, where you give dobutamine and nothing happens essentially. Stroke volume doesn't budge. Mean gradient remains in the mild to moderate range, and valve area remains in the severe range. This is a very challenging group of patients. So these are the patients we call lack of contractile reserve. So what is contractile reserve? So this is defined as a 20% improvement in stroke volume when you give dobutamine. And again, that can happen during any stage of dobutamine. It doesn't have to be at peak. That's why it's important to check with every stage. There's a study in the European guidelines, and I think that's what drives most of the guidelines now. It's this study here. This is a French study. Actually, it's a multi-center, but the main authors are French. That looked into these patients, and what they showed here is, as you see, the group 1 are the patients who have contractile reserve. Group 2 are the patients who do not have contractile reserve. So what you see is the outcomes of patients with contractile reserve is always better. However, why this study was important, because it showed that patients, even without contractile reserve, you do improve their outcome by doing aortic valve replacement. Well, the cost of that is a 33% mortality. So these patients are high-risk patients, high mortality, but if you get them through surgery, they do better long-term as compared if you treat them medically. And that's what drives the guideline, essentially, this one paper here. So in summary, that's what we know here about this current guidelines. If you have a patient with low flow aortic stenosis with reduced ejection fraction, you give them dobutamine. If their valve area goes above 1, mean gradient remains less than 40, that's not severe AF. If their valve area remains less than 1 and mean gradient go above 40, this is severe AS, and they benefit from intervention. Then we have this group that is essentially lumped now with severe AS group, as I said, because they benefit from surgery, where they have no contractile reserve, their valve area remains less than 1, mean gradient remains less than 40. So let's think about some of these concepts first. So is the definition is correct? I mean, do all patients with low ejection fraction have really low flow condition? I mean, that's what we use as a definition of this condition here. And we know this is not true, actually, and we know that from the heart failure data that majority of patients with stage B heart failure actually have a normal stroke volume. So this is back to the case we showed. So if I show you this set of data here, this is the patient where he has low ejection fraction, he has discrepant hemodynamics, but his stroke volume is 82 and stroke volume index is 47. So this is a patient that has actually a normal flow condition. So did he really need a dobutamine stress echo? I mean, that's an important thing to think about. I mean, are we stressing the right people? Are we doing the right thing by just going by EF? And what did we achieve by giving him dobutamine? We just made his EF look better, but he was already at a normal flow condition. So that's something to think about. And as you see, I mean, really, we were able to get his gradient to above 40, but did we really need to stress this patient? I think that's the main question. And on the other hand, we have this patient who have a completely normal ejection fraction, but have a stroke volume index of 26. So this is a patient, again, the EF does not correlate with flow rate, or with the flow, or with your flow condition. So because of this, people start coming up with other definitions of low flow, and stroke volume index came up as one of the ways to define low flow conditions. Now, the number we use in the current data, or current guidelines, is 35 ml per meter squared. That's kind of the golden number. Now, again, we really don't use this in patients with low ejection fraction. We still just stress these patients anyway. Nobody pretty much calculate the flow or the stroke volume index on these patients. It's mainly for patients with normal EF to explain their discrepant hemodynamics. If you see where this number came from, actually it didn't come out of any data. It's just kind of an arbitrary number. People looked at large number of patients and came up with this number. Doesn't mean really that if you're 34, you're low flow, you're 36, you're just fine. This is kind of a spectrum, and that's what was shown afterward in other data, is that once you drop below 40, the outcome changes and becomes to get worse. And then 30, there's nothing magic about 35, but that's what the guideline used, so we just have to know. So I think the important first message from this talk is that stroke volume does not equal ejection fraction. We have to think about why are we stressing these patients, what are we trying to achieve by doing so. So I'm just going to take this another step further here and talk about flow rate, because we call it low flow aortic stenosis and we never calculate flow, we never talk about what flow is. So what is flow? Flow essentially is the volume you eject across the aortic valve every second. So if you know your stroke volume and you know your ejection period, it's easy to calculate the flow rate. So if you think about it for a second, I mean, what really determines the aortic valve opening? It's not really your ejection fraction, that has nothing to do with it. It's not even the volume that you eject across the valve. It has a part of why the valve opens, but how long it takes to eject that volume also plays a major role. If you have two ventricles, both generating 50 cc, how long, over what period of time they're ejecting this volume also makes a difference, and that's exactly what flow rate is. So again, in the echo lab, it's easy to calculate, and I'll show you an example here. If you know your stroke volume, you calculate the ejection time from a continuous wave Doppler, and you can calculate your flow rate. The unit is usually ml per second. Now, the normal rate has been kind of debatable. If you look at most of the US data, and actually that a lot of it is invasive data from back in the 90s, 200 ml per second was reported to be the normal flow rate for everybody. Canadian guidelines are a little bit different, and majority are established by Philip Figueroa, who had a paper on this, and he used 250 as the cutoff. So I think that's one of the things that still needs to be defined, is what's exactly the right cutoff. But it's somewhere between 200 and 250 ml per second. So this is just an example in the echo lab how to calculate. You know, you have your LVOT diameter, you have your VTI, and through that you calculate your stroke volume. And you just divide it by the ejection time across the aortic valve. Now you can use the pulse Doppler or continuous wave Doppler. The continuous wave it's the same. So continuous wave just gives you a CRISPR image or CRISPR data, so you can calculate through that. So it's an easy calculation. So let me show you an example of this. So these are two patients. Both have aortic stenosis, both have low ejection fraction. So let's look at their data here. So the first patient, stroke volume is 55 ml. His stroke volume index is 31. Second patient is very similar, 53 ml and 29. Aortic valve area in both patients is essentially the same, 0.76 and 0.74. But the first patient is generating a mean gradient here of 26. The second one is 36. So why is that? I mean, they have the same EF, they have the same volume, essentially they're ejecting across the valve. The reason is, look at the first patient. He has a narrow QRS, short ejection time, 250 milliseconds, compared to the second patient who has a synchronous ventricle. His ejection time is 310 milliseconds. So this patient is generating a flow rate of 215 ml per second. This patient is generating a flow rate of 179. So that's why the mean gradient is different. So this brings two questions. First of all, I mean, this patient essentially is probably in the normal flow rate, although his ejection fraction is low and his stroke volume index is low. But he's generating enough volume because he's just squeezing this volume in a short period of time across his valve. So the first question is, do we really need to stress this patient? Do we need to do the dobutamine on him? That's the first question. The second thing is, we know this, I mean, although these patients have the same valve area, they have the same stroke volume and ejection fraction, are they the same, or this patient is really a sicker patient than this one? And I'm going to show you more data about this. So this is a paper that came in JACC Imaging a couple of years ago. Actually, it didn't get a lot of attention. I think it's an important paper. So what these people asked exactly the question I'm just proposing here is, if you calculate the flow rate on patients with low ejection fraction and low stroke volume index, and their flow rate at baseline is more than 200, which is normal, do we need to do dobutamine on these patients? So what they showed that if you're starting with a flow of more than 200 and you give dobutamine to these patients, their valve area doesn't change, as compared to patients who have a flow less than 200, where their valve area changes when you give dobutamine. So that again raises the question is, what are we achieving by giving dobutamine to patients with a normal flow rate to start with? I mean, although there's only 19 patients, as you see in the group where flow rate is less than 200, But this is a concept that's coming, so it's important to understand. I think we're gonna just see more data coming out of this. So another message here is that flow rate is different from stroke volume, and it's different from ejection fraction. And again, we have to think about why we're stressing these patients and what we're trying to achieve. What we're trying to achieve is really opening the aortic valve, not improvement in ejection fraction, not improvement in stroke volume. So I'm going to show you some of the work we've done on flow rate when I was at Mayo. So the main thing I was interested in about this project was, can I better risk stratify patients based on flow rate rather than stroke volume? Because as I showed you, when you add the time factor to the volume, it really makes a difference. And it might show you that two patients that you think are similar are not really similar. So we took 70 patients who were submitted to the echo lab for a dobutamine stress echo for suspected low flow, low gradient AF. 53 of them truly had severe aortic valve stenosis after dobutamine. Almost half of them had contractile reserve with a mean gradient more than 40 with dobutamine, and the other half had no contractile reserve section. And then just put here for you like how these patients were treated and how we followed them. The important thing is what you see here in this study, which was not available in other studies, that some of these patients got TAVR. All the other studies that looked into this and looked at contractile reserve, all the patients got surgical AVR. So this is kind of one of the changes about this. So this is just more kind of a proof of concept. If you truly have severe aortic valve stenosis with low ejection fraction, you do benefit from aortic valve replacement. We already know this, but more kind of a proof of concept here. So this is, I think, an interesting information here. We looked at the effect of contractile reserve on mortality. And in our data here, contractile reserve did not predict mortality. Actually, the outcome of patient was exactly the same, whether they had contractile reserve or did not have contractile reserve. And both groups had significant improvement with aortic valve replacement. Now, I think there are multiple explanations to this as to why this data contradicts the old data or the current guidelines. I think one thing is the old data was published where really heart failure therapy was not as advanced as it is now. Now we have more treatment. Patients do better overall. I think the other important thing here, you don't see the sharp drop in mortality or sharp drop in survival in patients with lack of contractile reserve. I think TAVR had changed this equation here. So then we started to look at the flow rate. Can we risk stratify patients based on flow rate rather than stroke volume? And actually what we showed is that at every flow rate, every cutoff we used, patients who had higher flow rate did better than the patients who had lower flow rate. When we did multivariate analysis and we looked at different cutoffs, we found that in our population at least, 230 ml per second separated the outcomes with statistical significance. So in our population, we use 230 as a cutoff for normal flow here. Again, I mean, that has to be established in big trials, but at least in our data, that was the number we saw. Now, what's interesting also is that we were able to show this concept of flow reserve. So if you're starting less than 230 ml per second in flow rate, and you give dobutamine and your peak flow improved to more than 230, the outcome was better if your flow rate does not improve less than 230. That shows that this ventricle has some reserve still able to improve the flow. And more interestingly, patients who have very low flow rate, even at baseline. So if you're starting less than 200, that's a really sick ventricle. It's not contracting, and it's very dysynchronous usually, wide QRS. So we showed that this patient actually, even if they got AVR, they had no significant improvement in survival, as compared to patients who started with more than 200. Now, again, this is a small study, but majority of these studies on this topic were small. So, and I wouldn't worry much about the numbers. It's more of the concept here. Is that, as I said, flow rate is different from stroke volume, different from ejection fraction, and I think it's something that's coming. You're going to see more of it, so it's something that we should start thinking about more now and can calculate more in the echo lab. In our data, at least, we found it to be a better prognosticator than contractile reserve. And then we need more studies to decide who we need to stress. Again, I mean, do we really need to stress every patient with low ejection fraction? We are suspecting they have low flow aortic valve stenosis. So I'm going to show you over the next slide here a case that I saw in the clinic last year. And I just to summarize how I think understanding of this concept of flow rate can have a clinical use. It's not just a research tool. So this is a fairly complex case. It's a patient who has non-aortic stenosis, what used to be called as moderate before, has chronic atrial fibrillation. 6 months ago, he had a dual chamber pacemaker for tachybrady syndrome. Over the last 3 months, he didn't do very well. He was hospitalized 3 times. So he was actually referred to us from Iowa with worsening. They assumed that his ejection, and he had a drop in ejection fraction. His ejection fraction was normal just a year ago. The thought was it was due to worsening aortic valve stenosis. So his EF is now 35%. I'll show you some more images here. Now the aortic valve area is 0.8 with a mean gradient of 22. And he has some AR and MR on top of that. That's his external lung axis. You see low ejection fraction, calcified aortic valve with restricted leaflet excursion. Just some more images of the close-up on the valve with the long axis and short axis. Can take this a minute to load, but again, you see low ejection fraction. You can see the pacemaker wire there. He does have MR and a little bit of AI. So the question is, first question is, what do you want to do? So again, the patient was deemed a high-risk surgical can. He had severe peripheral vascular disease. He had chronic kidney disease. His baseline creatinine around 1.4. So he was actually sent for TAVR workup when he was sent to us. This is X-ray. He had some interstitial edema. He has, you see the pacemaker there. His NT-proBNP was 23,000 when he came to us, and his creatinine was 1.8. His baseline was 1. As I said, 1.3 or 1.4. This is EKG. See his RV pace. So, question is, what do you want to do next with this patient? Should we just proceed with TAVR on him? I mean, the valve looks bad. Should we do balloon angioplasty and see how he does? Should we just do a mitral clip? Because we can. Should we do dobutamine echo just to further understand his hemodynamics? Or should we do an angiogram and bilateral heart cath to further understand his hemodynamics? I'm going to keep going. We decided to do dobutamine echo. We believe, yes, at this point, yes, we don't have enough data to say that this is severe AF. Again, he has a low ejection fraction and he has discrepant hemodynamics. So this is his resting data, LVOT 2.2, and again, remember this doesn't change with stress, so that remains the same. So stroke volume at rest 49, stroke volume index 26 ml per meter squared. Mean gradient is 20 and valve area is 0.8. So what happens at peak dobutamine? Stroke volume does improve to 65, but remains low. Now his mean gradient is 26 and valve area is 0.8. Now, which category does this patient fall in? Really not in any of the categories I showed you, because his stroke volume did improve by 20%, although it remained low. And he didn't really improve his valve area to above 1 or his mean gradient to above 40. So we started with discrepancy, we end up with discrepancy. And he doesn't have, I mean, he has contractile reserve. So still, I mean, where do we put this patient? What do we do with him? I mean, majority of people would send this patient for TAVR based on this data because his valve area didn't improve. But what we thought here is we still don't have enough information to say so. But this patient really never improved his flow enough to show what his valve area is. So as I said, you know, what do you still want to do with him? And as I said, most people would say that maybe we should just proceed with TAVR for him. His just valve area remains low. So let me show you what we did. So again, this is the data here. We calculated his flow rate at baseline and peak. So his flow started at 144 and got to 163. So it's really very low flow still. I mean, we have not normalized this patient's flow yet. So it's still not clear what his valve hemodynamics are. So there is some data about projecting the valve area. This came in 2006. It's also Canadian data. So what this paper showed is that there is a linear correlation between the flow rate and the valve area. So if you have valve area at 2 different flow rates, even if you don't normalize the flow, you can draw a valve compliance line. You can project your valve area, what your valve area would have been had you really improved your flow all the way back to normal. And based on this, they came up with a regression equation as to calculate, like, you know, for example, let's assume the flow rate is 200 ml per second. And I have 2 different times with the flow, which are 144 and 163. Based on these 2 points, I can draw a valve compliance curve. I can project the valve area for this patient. And this is the equation they used. Again, it's a regression equation based on this data. And when we calculated that on this patient, his projected valve area was 1.1 at the normal flow rate. So that makes things more complicated. I mean, now this patient we're saying is probably moderate. So what do we do with him? So let me show you what we did. We decided to add an LV lead first, because I mean his story really correlated that when he got his pacemaker is when he fell first, and his ejection fraction dropped. So we thought that rapid progression of aortic stenosis didn't make a lot of sense. And let me show you what happened with him. So baseline EF 27, after 1 month it was 33, 4 months it was 58%. This is his MR at baseline, and this is after 1 month, this is after 4 months. Stroke volume was 26 ml per meter squared to start with, was 40, and then 45 or 48 after 4 months. So now he normalizes flow. And look at his valve hemodynamics. He starts with 0.7 valve area and mean gradient of 20. After a month, his valve area is 1.1. It's actually exactly what we projected. His mean gradient remained in the moderate range. Then after 4 months, it's not going to go up further because that's what his valve area is. And that's where he settled essentially after improvement. So truly, this patient had moderate aortic stenosis to start with. And all he needed is just more synchronization of his ventricle. So I think that's how I think this concept is helpful when you see these patients in clinic or in the. This is him after 4 months. His NT-proBNP now is 2,500, and his creatinine is back to baseline, and he was feeling 100% better. That's that. So for the next few minutes, I'm going to switch to another topic here really quick. I'm just going to shift gears and talk about atrial fibrillation and aortic stenosis. That's one other area that we did some work on. So the combination of aortic stenosis and atrial fibrillation is very common. So if you look at the whole population, there's a 1 to 2% prevalence of atrial fibrillation. Now, if you look at patients with moderate AS, that goes up to around 9%. So even with just moderate AS. Now, if you look at the some of the TAVR registries, so if you look at the French database, around 26% of patients with severe AS at presentation at baseline had atrial fibrillation. From the PARTNER 1 trial, 37%. If you look at some of the data from low flow, low gradient aortic stenosis, these are the sickest patients. Almost half of them have atrial fibrillation. So this is a very common combination. Now, why do we care? Well, because it's very hard actually, and you always feel this, that you don't have a good grasp when you see these patients in the echo lab about how to grade the severity of aortic stenosis. Almost all of them have a low flow condition, and you have this beat to beat variability. So we sit down and average their beat, and then you don't have the confidence when you call eventually the aortic stenosis. So first, the question we ask is, are we doing the right thing by averaging signals on these patients? So why do we average? Because the guidelines ask us to average here. So this is what this is actually from the ASE guidelines. And they tell you that to choose 5 cycles where heart rate is close to, as possible to the normal heart rate. I don't know what that means. But, you have to average 5 cycles. And, if you see the references or the citation, there are no citations behind it. So they sat down and came up with this. And there was no reference or anything for this. So let me show you a case here. Again, this is a case we saw in the valve clinic. This is, again, a 73-year-old patient. He has non-aortic stenosis, and he has persistent AFib. We saw him for an opinion about his aortic stenosis. Again, this is his long axis and short axis. I mean, it's a bad-looking valve. And then you have, again, signals all over the place. It's really not that tachycardic. So he has signals that goes above 40. So you have this signal here that goes above 40 millimeter mercury, and then the rest of the signals less than 40. So he averaged to less than 40. So the question is, does this patient, should we use his average and call him moderate AS, or should we use his peak and you call him severe AS? So this is, his valve area is 0.7, stroke volume is 71, and his stroke volume index is 50. So that's what the report called him. He called him moderate to severe AS. Although they put the valve area there of 0.7, but I think they were hesitant to call it severe with an average gradient less than 40. So we sent him to the for surgical evaluation. Again, when the surgeon saw him, we can monitor this for 3 more months and see what happens to the gradient. And in a month, this patient presented with sudden death to the ER. So this raises a question here is, are we doing the right thing by averaging signals on these patients? And is it truly that we should look more at mean gradient than valve area in these patients? So this is another thing we looked at in more detail. So this is a part of the study actually we did. I'm not going to present the whole data. But we took everybody with a valve area less than 1 who had aortic stenosis and atrial fibrillation in 2 years period from Mayo Clinic database. And then we looked how are we doing by calling these patients, first of all, and then what the outcomes overall of these patients. And how are we doing by referring them for aortic valve replacement. So this is kind of a breakdown of how we put the data together here. So again, all these patients had a valve area less than 1 and had atrial fibrillation at baseline. We divided them into 2 groups. One group that had an average mean gradient more than 40, And we call this a high gradient AS group. And this is a no-brainer to severe AS. We have another group that had a valve area less than 1 with a mean gradient less than 4 or a velocity less than 4. We call them low gradient aortic stenosis. Now, out of these, we went back actually and looked at their echoes. And what we found is that almost a third of them had one signal there in their echo that exceeded 40 millimeter mercury or 4 meters squared, also 4 meters per second of velocity. And 2/3 did not. So how are we calling these patients on the report? So again, it's easy for the high gradient AS, everybody calls them severe, that's easy. But what are we doing with the other patients? So if you have low gradient AS, less than 40% were called severe, majority were called moderate to severe. Even patients who had at least one high signal, most people went by the average mean gradient, and only in 40% of the time they were called severe. Majority of the time they were called moderate to severe. So let's see if the outcome really different. I mean, we're calling these patients differently in the report. Is the outcome different? So we look first at these groups in red here. Low gradient AS and high gradient AS, we have AFib. And essentially the outcome was the same. This is on medical management. So if you don't operate on these patients, they do very poorly long term. There was no difference in outcome. So then we looked at the subgroups here. Does it matter if you have a high gradient on your echo or not? And how does that compare to severe AS, like patients who generated a high gradient? And pretty much everybody was the same. I mean, all these curves are essentially superimposed. I mean, there was no difference at all, suggesting that all these patients had the same outcome, whether they generated a high gradient or did not generate a high gradient. So how are we doing by referring these patients for aortic valve replacement? Of course, high gradient AS they had the highest chance of being referred. Low gradient AS, although I just showed you they have the same outcome, only around 25% were referred for aortic valve replacement. Interestingly, patients who had some high signals on their echo report had a higher chance of being referred, but it's still not even close to what we do when patients have high gradient AS. So who benefits from aortic valve replacement? Essentially everybody I showed you benefits from aortic valve replacement. So this is the high gradient group, this is the whole low gradient group, and this is the breakdown, whether they had a high signal or low signal. So just focusing quickly on this group here. So we have a group of patients where we are averaging their mean gradient to less than 40 and calling them moderate, sometimes moderate to severe, but we're rarely calling them severe. But we know their outcome is as bad as severe AS patients. And we're under-referring these patients for aortic valve replacement. So really, had we used the highest signal that we had available rather than the average signal, we had a 30% chance of proving our accuracy of grading the aortic stenosis in these patients. And we've probably would have done a better job sending these patients for aortic valve replacement than what we do now. Now this is interesting. If you look at the multivariate analysis, these are the predictors of mortality in all these patients. The strongest predictor of mortality was the aortic valve area. Look at the mean gradient. It actually was non-significant. So these are patients who live in a low flow state. They're not able to generate a high gradient. And we're still very focused on the mean gradient in them. And almost half of them cannot generate a high gradient. So I understand that aortic valve area is a calculation, but it's actually, if it's done well, as you see, it really predicts mortality very well in these patients. And the reason why valve area doesn't change much, because it's a ratio between the LVOT VTI and aortic valve VTI. So if you average both, you're still going to get the same valve area, whether you use the highest signal or the average signal. That's why it stays the same, while the mean gradient will change based on your flow state. So again, we have this group where actually we're really under-referring them for AVR, and I showed you their outcome is very poor. These are just patients that just cannot generate a high gradient, and they don't have high signals on their echo, but they still have a valve area less than 1. So I'm not saying we have to send all of them for aortic valve replacement, but we have to think about these patients more right before we say they don't have severe AS because their mean gradient is poor. So let me show you an examples here, a couple of examples of patients who have atrial fibrillation and aortic stenosis, and then what happened when they went to sinus rhythm. Because that will show like what does it compare to the gradient in sinus rhythm and atrial fibrillation. So this is a patient with non-calcified aortic stenosis. He has no mean gradient of 34, 35 just from a couple of months ago. He comes to the emergency with atrial fibrillation. So this is his baseline gradient, baseline echo. As you see, his mean gradient is 34, valve area is 0.7. He goes into AFib. Now his mean gradient is 17, and 17 is the highest signal we've seen there. Actually, if you average, his mean gradient is only 15. But valve area doesn't really change much, because again, the LVOT VTI will go down and the aortic valve VTI will go down. So the ratio will not change But the mean gradient did change and changed significantly. So if you see this patient, I mean, it's hard to call this patient severe based on what you see here. But you have to really investigate this further before you just, brush it off and say this is not severe AF, it's too low of a mean gradient. There's another example. This patient had 2 echoes just 5 days apart. So she has non-hypertension. She came with shortness of breath. So this is before she got her cardioversion. So this is her echo in the emergency. Stroke volume index of 32 and valve area is 0.7. Her mean gradient is 24, 26. And as you see, she's not tachycardic. I mean, they don't have to be tachycardic so that for them not to generate a high gradient. They just lose their atrial kick and their flow rate, or their flow state is now low. So again, this patient in the 20s, she gets cardioversion. This is her echo 5 days later. Her mean gradient now is 42. So there's a big difference. And again, you don't have to have a high signal, but when you see a valve, if you look at the valve area, it doesn't change much. So when you have a low valve area in these patients, I think it's worth further investigation. Again, I'm not saying we should send all of them for aortic valve replacement, but it's probably worth looking further into this. So the conclusion from this, that what we thought that when we average signals, we're really underestimating the severity of aortic stenosis in these patients. Again, these are patients who have a low flow condition. Their mean gradient is low because they cannot generate the gradient. On top of that, we average, so we even lower it further. And because of that, we're under-referring patients with aortic stenosis and atrial fibrillation by averaging their signal. In our database, aortic valve stenosis was the strongest predictor in mortality in these patients, and mean gradient really did not correlate with mortality. So we have to look further into patients with a valve area less than 1. And we thought based on this data that we should use the highest signal we see on echo rather than the average signal. Some of the other work we're doing, we're looking at patients who have, we're doing this more of a prospective way now. We're taking patients before cardio, any patients with AFib and aortic stenosis who are sent for cardioversion. We're doing a limited echo before, a limited echo after, just to compare the gradients and how the gradients in normal sinus rhythm correlate to the gradients in atrial fibrillation. So this is a prospective trial we're doing now. Another, I think, interesting topic we see is somebody like this. Somebody has a PVC, and their mean gradient goes to like 45, 50. What do we call these patients? I mean, what we do now is we average these two, and we call it somewhere in the middle. But is that correct? We just don't know that. So what we're doing is actually we're putting Holter monitors on these patients, see how many PVC they have. Because the question is how many times a day the valve would have to see a high gradient before the outcome changes. We just don't have an answer to this. Does it have to be with every beat or half of the beat, third of the time? So that would be a nice thing. It's a complex study to execute though, because there are other reasons why people have lower mortality when they have PVCs, maybe coronary artery disease or something. But we're working on this one. But that's it. Just submit for questions.
That was fantastic, Saeed. I guess I can conclude that by eliminating PVCs and AF ablation will treat all aortic stenosis. So it's all about EP. But two questions. In someone with severe mitral regurgitation, how reliable is dobutamine echo, when the flow could go either way? And the second question is related to atrial fibrillation. Actually, I'm having a tough time relating the atrial kick as the main contributor to the difference. And actually, I'm very curious to look at your study because immediately after a cardioversion, I'm not sure that your atrial is kicking. So I'm really curious to see what that shows if you're going to do this study. So
first of all, for mitral regurgitation and stress testing, I don't think we know exactly what happens to the mitral regurgitation. There's some data about putting patients on bicycle echoes. It's a little bit hard to predict what's going to happen to the MR. In some patients, the MR does get to the severe range. With dobutamine, I don't think we have a clear understanding because it's also a vasodilator. So there's some decrease in systemic vascular resistance. So whether in some patients it gets worse, some patients improves. I don't think we have a clear understanding. But even in patients who you put on bike and their MR goes from, let's say, moderate to severe, we know these patients' mortality is higher, but we don't know what to do with them yet because we don't have any data to suggest that if you operate on these patients, that improves their outcome. So this data is still, I think, is not entirely clear. As to some of these patients, I agree with you. That patient was a little bit unusual there. Is it just related to the atrial kick? That's the question. We don't know if it's really related to the atrial kick. I think to some degree is what we measure the ejection time on these patients actually changed between when they're in atrial fibrillation and when they were in sinus rhythm. So is it just more effective ventricular contraction as well? I don't know. But we have actually a case series of multiple patients who after cardioversion, their gradient significantly went up. I agree with you. It cannot be just due to atrial kick because it's still not time for the atrial kick to cause any improvement there. It has to be with something else, but I think we're still looking into it.
Yeah, that question has actually been looked at, and if you take patients in atrial fibrillation and you record the ventricular response, you record the RR interval, and then you look at the hemodynamics, pacing them at the irregular rhythm that they had, and then you ventricular pace them at the same average heart rate. What you find is that the cardiac output is lower and the wedge pressure is higher when they're irregular, even though they have the same average heart rate. So actually the irregularity has an impact on both the hemodynamics, the cardiac output, and the wedge pressure. I mean, I don't want to imply that the atrial kick has no impact. Obviously it does. But, you know, it has been established by at least 2 or 3 studies that simply the irregular rhythm, independent of the average heart rate, has an impact.
Even when the rates sometimes are not too high, patients sometimes feel better just when they're in regular rhythm, even if they're still in AFib when we do AV node and a pacing.
Subtle change in the wedge or the cardiac output, you think of it, I mean, it's quite a significant drop.
That was excellent. I'm trying to understand the value of the calculated aortic valve area. And in cross-sectional imaging, it's clear that there's quite a variation in the spherical or elliptical nature of the outflow tract. And when you make a linear dimension for your calculation, you may or may not be estimating a circle. And so if you were just using dimensionless index, isn't that a way to eliminate some of the error that you might otherwise introduce?
Right, and actually we looked at the dimensional index, and that also correlated very well with the mortality. I think that's true, and you're right. I mean, you know, from the CT data, we know that if you're going to use CT data to define aortic stenosis, the cutoff should be higher, maybe 1.2. But I think what most of our data now are based on aortic valve area that's measured the way we measure it from Doppler signal and using the LVOT diameter we use with just one dimension from there. And, you know, although probably is not a good calculation, but, you know, 1 centimeter squared, I mean, seems to be correlating well with mortality, at least from different data. But I agree. I mean, you know, dimensional index might be just probably a better way of looking at these patients. And again, as you said, you know, the ratio will not change in atrial fibrillation, whether they are in atrial fibrillation or aortic or sinus rhythm, because the LVOT VTI and the aortic valve VTI both will go down in atrial fibrillation. So the ratio will not change. So the aortic valve VTI will remain stable, whether you're in atrial fibrillation or sinus rhythm. But the DI will do the same as well, absolutely.
Saeed, I think that was an outstanding presentation. A couple of points. I think it would be nice to put the valve flow on the echo reports. And I know Richard is sitting right over here. He can make that happen. But I think it would be useful. And I think, I'm an amateur in this area, but I think that the guidelines have a very misplaced emphasis on gradient. And we get a skewed view in the cath lab, particularly these days. We usually don't see patients that have a mean gradient greater than 40 because their decision's already been made from their echocardiogram. But there is a huge number of patients that come to the cath lab that have mean gradients way under 40 that have, if you accept 1.0 as severe aortic stenosis, have severe aortic stenosis. And in fact, if you just look at the Gorlin equation, for many patients with a cardiac output of 5 liters per minute and a heart rate in the 70s, their mean gradient is going to be well, and a valve area of 1, their mean gradient is going to be about 25.
Right, exactly. And there's some data, like in New England Journal paper from Blaise Carabello, what he showed is that to generate a gradient of 40, you have to have a valve area of 0.8, not 1.
Yeah.
So using 1 maybe is just too generous there.
Well, but maybe using 1 is correct and not focusing on the gradient.
Right, exactly. I mean, the outcome changes with a valve area of 1. So that's how they base the severe AS based on.
Right, and I think
it doesn't have to generate a gradient.
I think the focus on the gradient is probably misplaced, and particularly like with the atrial fibrillation, as you said, your valve area is not going to change whether you take the higher gradient or the lower gradient. And I think that just underscores the misplaced emphasis on the gradient and how we, I think, should be relying more on the valve area. And I think the echo readers as well should try and reach a consensus about what's going to be called, because you see a lot of these echo reports where the valve area is 0.8, the gradient's 24 or 30, and the report is moderate aortic stenosis.
Sorry to trump you, Mike. That's a corollary to Ray's question. What about the use of nitroprusside instead of dobutamine in this situation, especially if there's a lot of mitral regurgitation?
So actually, that's what we use mainly for patients with preserved ejection fraction. I mean, I think it depends on what we're trying to achieve there. So in patients who have a normal EF, it doesn't make sense to use dobutamine because they already have a normal ejection fraction. They have a good contraction. So in these patients, we were using more nitride at least when I was at Mayo. Because the main problem with these patients is just very high systemic vascular resistance. So it makes sense to use dobutamine in these, nitride in these patients. In patients with very low ejection fraction, I think it depends probably what their systemic vascular resistance is when we measure it in the cath lab. So if their systemic vascular resistance is very high, I think using nitride instead of dobutamine would be another way to stress them rather than using dobutamine. That's correct. For mitral regurgitation, I don't think we have data about this, but it also makes sense that if you vasodilate these patients, will that improve their MR, and do we need to do something about the MR based on that? I don't think anybody looked into this before.
Saeed, nice presentation. Are we at the point now? Are we at the point now where we should eliminate the term moderate to severe aortic stenosis? Because it's not, it gives us comfort, and so we're making a diagnosis, but that isn't a diagnosis, and it's saying that we are unable, based on the current data, to define whether it's severe or moderate, and then perhaps eliminate that word and say it's indeterminate, and then have the echo report suggest the next step to evaluate. Is it a dobutamine stress echo? Is it going to the cath lab? Commenting on that, because the data flows on these patients, and they're very, very difficult, as your presentation commented on, to cleanly categorize. Is that an appropriate?
So I mean, I would agree definitely with the second part, that the echocardiographer has to guide whoever ordered the report as to what to do next. Now, there are cases sometimes that still are very difficult. I find them I try not to put moderate severe, but sometimes it's hard not to do. I mean, we rarely have to do it sometimes. I mean, we have patients who have a valve area, let's say 0.9, and mean gradient, let's say 25. They have a normal flow rate. So what do you call these patients? I mean, if you tell them this is severe, this patient, you committed this patient to more workup or more intervention, probably TAVR, and we're still not 100% sure, because there are patients who have normal flow low gradient. There is this group of patients. Actually, it's not a small group of patients. Have completely normal flow. They have a valve area less than 1, but their gradient is low. So they're called normal flow low gradient. And I don't think we have good understanding yet of what the outcome of these patients. Some people, like from Philippe Bibero and Canadian, think the outcome of this patient is as bad as severe AF. There's some data actually from the US said that their outcome is similar to moderate AF. So I think what we should do, if I put moderate to severe, we have to guide it further, like for the person who ordered the report, so they don't ignore the data. Maybe getting, as you said, like an invasive hemodynamic study or a calcium score of the valve, or some more data to further follow on this, rather than saying this is either moderate, just ignore it, we'll see you in a year, or this is severe, you have to go now. I think when we say that, then we're hedging, but we have to further follow on that by saying what to do next. That's what I would do if I put moderate to severe in the report. But I don't think we're at the point where we can clearly say this is moderate or this is severe, because there's still a group of patients that we don't know exactly their outcome, and we have to hedge about them a little bit.
How does the cath lab fit in for you?
Actually, personally, honestly, I don't usually order a lot. I mean, what I trained is we did a lot of CT calcium scoring, and I believed in that data. So that was usually my next step when I have some discrepancy. I think when my exam, so when the echo shows me, the only time when I send really a patient to the cath lab myself is when the exam is definitely not consistent with severe AF, while the echo does suggest severe AF. I've seen a couple of cases where these patients, their highest gradient was obtained from like the supraclavicular, and they end up having actually stenosis in one of their major vessels. And that's why you're picking a high signal. But their exam was clearly not consistent. So this is a case where I would send a patient to the cath lab. But if you have discrepant hemodynamics, I don't see how the cath lab would clear this unless you're thinking there's some major measurement issue in the echo you have, or the images were not good enough so that you can make a final judgment. But I think when there's a big discrepancy between your exam and the echo results, that's one way to clear it. Although personally, I prefer to go for a calcium score of the valve, because if that's in the severe range, you're pretty much done. If it's more than 2,000, if it's low, you're still stuck. I mean, I don't think so you're going to still need more data based on that.
I think with regard to the question of moderately severe, though, we're always stuck with the dichotomy of 0.95 is severe aortic stenosis and 1.05 is not, or 1.01 or whatever. That's a further complicating factor. And I can't remember, is the valve area index reported on?
So valve area index, I mean, there was a lot of interest in it before. It kind of died because, what's the cutoff? 0.6 was used as a cutoff. And then some people said, well, 0.6 is not good enough. You have to use 0.5. So that's kind of a moving target, and people moved away from it because of that, because I don't think we have a well-defined cutoff to say when this is severe or not.
But I think it can be helpful, because the 110-pound woman versus the 6'5", 260-pound man who have the same aortic valve area, I mean, it's ridiculous to think that
it is. I mean,
that equates. And I
right.
think having the valve area index is just another piece of information that can help, along with the dimensionless index and possibly a calcium score, can help kind of put it all together.
Right. It might. I mean, if it's clearly in the severe range, maybe it would help. And then, there's at a certain body surface area, I think it falls apart the whole equation as well. So it's, it's not very easy to use, I would say, this concept. If it falls or lines with the other data, it might help. But I wouldn't use it by itself, like just to clearly say this patient goes for severe AS or not.
Is it enough to just say go to valve clinic?
Probably. I mean, whenever it's out, it's probably easier.
I think there's a certain danger in focusing on one parameter to assess the severity of the aortic stenosis. If you could pick one parameter to evaluate, it would probably be a detailed assessment of myocardial mechanics. Now, the impact of the aortic stenosis and the work done by the ventricle is influenced by the pressure recovery. So you could have identical gradients in identical areas measured by echocardiography with, excellent accuracy. And if your aorta is 4 centimeters versus 2.5 or 3 centimeters, it makes a huge difference in the amount of pressure recovery and in the work done by the ventricle. So I think that, I don't know that there will ever be a situation where we focus on one parameter and say, okay, go to the OR, or go to TAVR. And that will explain a lot of the variability and the mystery that we sometimes encounter. This person has a mean gradient of 30 or 35 and is not symptomatic, and this other patient is symptomatic. And then obviously there's the question of what's the incremental contribution of the aortic stenosis on the ventricle, and that will vary from patient to patient. I think that, the challenge will be we're going to have an 85-year-old woman who's short of breath and is going to have some degree of aortic stenosis. And there are multiple reasons why that person is short of breath. How much is the aortic stenosis contributing? And I don't think we have the answer to that, and I don't think we're going to get it from the aortic valve area. I think we're going to probably get it from a physiologic study that looks at multiple parameters and not just the valve area.
Right. No, I totally agree. But what's happening is exactly the other way around. There's too much focus on the mean gradient and ignoring the other parameters. I think exactly putting it together is important. Pressure recovery is one other reason why I think going to the cath lab would be important. We recently had a patient who had a mechanical bileaflet valve, aortic who had who he was in the OR essentially on the table with a mean gradient of 46, and he was going to get his valve replaced, but in the OR with the TEE, everybody showed like the leaflets were moving just fine, and his gradient in the cath lab was only 13. So that's another reason when the exam findings are not consistent. I mean, I think that's another reason to go to the cath lab. And that was the case. They had to take him off. Right.
So is the cath lab the gold standard, or?
I think it has I wouldn't say it's a gold standard.
Okay.
To be honest, I think echo is the gold standard. But cath lab definitely clears a lot of controversies, like pressure recovery when your exam is not consistent and you're getting severe on the echo, or some other, like when you can't put it together. I think it definitely can help. But it wouldn't be. I mean, I wouldn't send every patient, but I would send some patients who are not clearly sitting in any of the categories.
Thank you very much, everybody. Have a great week. Great.